Hi, my name is Joe Kroll, and this is Dov Zeitman. Today we're going to be presenting a neuro case. Our patient is a 55-year-old male who came to a primary care office with right-sided leg numbness. Initially was intermittent over the last 2 months, but in the last week it has become constant. He describes the pain as pins and needles. Nothing makes it better or worse. It is down the lateral calf into his toes, and he also admits to some back pain in the lumbar region that has been progressively worsening for the last 6 months. Our differential diagnosis that we've come up for this case is some lumbar radiculopathy, slip disc or herniated disc, spinal stenosis, sciatica, vertebra fracture, spinal cord compression, peripheral artery disease, diabetic neuropathy, B12 deficiency, shingles, MS, hypocalcemia, and hypothyroidism.
So now we will begin the physical exam. The PA will begin the exam by assessing vital signs first. He would begin by measuring the height and weight of the patient. Now, he will be taking the blood pressure by making sure the cuff is the right size and positioning the patient's arm at heart level. He will be feeling for the brachial artery and making sure that the patient's arm is slightly flexed at the elbow. He will then palpate for the radial artery. He is inflating the cuff until the radial pulse disappears. The reading at which the radial pulse disappears, plus 13 millimeters mercury, is the target range to inflate to. He will then deflate the cuff and will wait for 15 to 30 seconds to recheck the pressure. He will position the bell of the stethoscope over the brachial artery to listen to the blood pressure. He will inflate the cuff to target level, and then he will slowly deflate the cuff at a rate of about 2 to 3 millimeters mercury per second. The sound of at least 2 consecutive beats will be the systolic pressure when first heard, and when the sounds become muffled and disappear, that will be the diastolic pressure. He would then repeat the blood pressure reading on the other arm using the same technique. Now the PA will be checking the heart rate by palpating the radial artery. He will be noting the rate, rhythm, amplitude, and contour of the pulse, and he will count for 30 seconds. If the rate or rhythm is irregular, he would be counting for 60 seconds. Now the PA will observe the respiratory rate. He is observing for rate, rhythm, depth, and effort of breathing. He will observe respirations for 60 seconds. He will now check the temperature using an electronic oral thermometer and read the measurement after 10 seconds. The PA will now observe the patient for general survey throughout the exam, making sure to note the apparent state of health, level of consciousness, distress, dress and grooming, personal hygiene, as well as facial expression, posture, gait, and motor activity. The reason for this part of the exam is to determine if the patient is in any state of acute distress or having any alterations in his level of consciousness. For the skin exam, the PA will inspect the skin for color, obvious lesions, rashes, warmth, or dryness, as well as inspecting the nail. One can see brittle nails, dry skin, and hypothyroidism or B12 deficiency, and ulcerations or diabetic ulcers in lower extremities. One will also notice vesicular lesions in order to help rule out shingles.
The PA will now inspect and palpate the head for signs of trauma. The PA will now check that the pupils are equal, round, and reactive to light for proper neurological function. They will then inspect the eyebrows for hair distribution and fullness. Lateral thinning of the eyebrows can be seen in hypothyroidism. The PA will inspect the tongue, noting any beefy red tongue which indicates B12 deficiency. The PA will inspect the thyroid for symmetry, masses, and observe the patient swallow.
Can you swallow?
They will palpate the thyroid from behind the patient, placing a finger below the cricoid, asking the patient to swallow while feeling for the isthmus and thyroid.
Can you swallow?
The PA will now attempt to produce a chopstick sign. The PA will percuss the top of the cheek just below the zygomatic bone in front of the ear using the tip of the index finger. A positive sign indicates hypocalcemia.
Sir, can you please pull down your gown?
The PA will now begin inspection of the chest for the cardio portion of the physical exam by observing the chest for lifts, heaves, and thrills, while making sure the patient has their hands placed on their hips. The PA will now begin auscultation of the chest for heart sounds. They will begin by listening at the right second intercostal space, the left second intercostal space, third intercostal space, fourth and fifth intercostal space on the left side, and the apex. The PA will be listening for 2 to 3 seconds each and will auscultate with the bell. Also, at the right second intercostal space, the left second intercostal space, the third intercostal space, the fourth intercostal space, the fifth intercostal space, and the apex. During auscultation, it is important to remember to use both the bell and diaphragm for 2 to 3 seconds on each spot. The PA will now begin the pulmonary portion of the physical exam by inspecting and conducting an initial survey for rate, rhythm, depth, and effort of breathing. They will also observe the AP lateral diameter ratio of the chest and will check for deformities, accessory muscle use, and tracheal position. They will now begin auscultation of the chest, and they will be listening for the anterior portion of the chest, and they will be listening through full inspiration and expiration. They will always tell the patient to breathe through an open mouth with his or her face turned away from the provider. Instead of telling the patient to take a deep breath every time, the provider can tell the patient, every time you feel my stethoscope touch your chest, please take a deep breath through an open mouth. While inspecting the anterior and lateral portions of the chest, they can have their hands on their hip, and while inspecting the patient posterior chest, they can have their arms crossed in front or in genie position. It is also important to remember to auscultate the apices of the lungs.
The lumbar spine for deformities, spasm, or curvature. Loss of lordosis occurs with paravertebral spasm. The PA will now palpate for vertebral step-offs, identifying any tenderness, paravertebral muscles. Step-off occurs in the forward slippage of the vertebrae, which may compress the spinal cord. Vertebral tenderness raises concerns for fractures, dislocation, and underlying infection or arthritis. Herniated intervertebral discs may cause tenderness of the spinous process, intervertebral joints, and paravertebral muscles and sciatic nerve. The PA will now test active range of motion. For flexion, he will ask the patient to bend forward and try to touch your toes. For extension, he will ask the patient to bend back as far as possible. For right and left rotation, the PA will ask the patient to rotate from side to side. For right and left lateral bending, the patients will be told to bend from the side of the waist, stabilizing the patient's pelvis by placing your hand on the patient's hip. Consider lumbosacral cord or nerve root compression if these maneuvers provoke pain or tenderness, particularly with radiation into the leg. The PA will now inspect the hip for deformity and color change. The PA will now palpate the sacroiliac joint and sciatic nerve. Sciatic nerve tenderness is seen with herniated discs or nerve root impingement. The PA will now be checking active range of motion by asking the patient to abduct, adduct, internal and externally rotate the hip joint. The PA will now be testing muscle strength against resistance, noting for abduction, adduction, internal and external rotation. The PA will now be inspecting the knees for swelling, effusion, deformities, nodules, and color. He will be testing active range of motion for flexion and extension. And testing strength against resistance for flexion and extension. The PA will now be checking the ankles and the feet, inspecting for swelling, deformities, nodules, and color. And will be testing active range of motion for dorsiflexion, plantar flexion, inversion, and eversion, as well as testing strength against resistance for dorsiflexion and plantar flexion. Bilateral distal weakness suggests diabetic neuropathy.
The PA will now begin the neuro portion of the physical exam. They will be assessing the patient's mental status, but for efficiency, portions of the neurological exam, such as mini mental status, can be combined with other parts of the patient's assessment. For example, the PA can assess the patient's mental status during history and interview while observing the patient's mental status, speech, mood, memory, and orientation. For the sensory portion of the exam, they will examine the lower extremities by first performing light touch test. The provider, while testing for light touch and contrasting between sensations, must demonstrate on the patient how exactly the test should feel normally. For example, on the upper extremity where the patient does not have any symptoms. The PA will then instruct the patient by telling them, each time you feel the cotton, you say now. Once the PA has touched one side, then the other, they will ask the patient, do they feel the same? They will then compare proximal to distal on the extremities. To test for sharp and dull, the PA will then use a sharp tool while occasionally substituting the blunt end for the point. They will ask the patient, is this sharp or dull? And they will make comparisons while asking the patient, does this feel the same as this? They will be evaluating the same areas as light touch. The PA will now begin to assess for vibratory sense on the big toe using a 128 Hz fork. They will tap the fork on the heel of their hand and place it firmly over the IP joint of the patient's big toe. They will ask the patient what they feel, and they will ask the patient when they feel the vibration stop. When assessing vibratory sensation of lower extremity, they should start at the big toe and compare sides. If vibratory sense is diminished, they will check more proximal joints such as the ankle, patella, and iliac crest. One pearl is that when examining older patients, you must keep in mind that distal vibratory sense may normally decrease with age in the ankles and feet, but not in the fingers or shins. Another pearl is that often this is the first sensation lost in peripheral neuropathy, and this includes diseases such as diabetes, alcoholism, posterior column disease, or B12 deficiency. The PA will now be testing for position sense. They will grasp the patient's big toe, holding it by its sides between the thumb and index finger, making sure to pull it away from the other toes. They will demonstrate for the patient up and down as they move the patient's toe. Now with the patient's eyes closed, they will ask the patient to say up or down when moving the large toe. One pearl is that loss of position sense, like loss of vibration sense, is seen in multiple sclerosis, B12 deficiency, diabetic neuropathy, or posterior column disease. Of the neurological exam was conducted previously during the musculoskeletal portion of the physical exam. The PA will now begin to check for deep tendon reflexes, first of the bicep. They will strike their thumb overlying the patient's bicep tendon. Now they will check the triceps reflex. They will strike directly behind and above the patient's elbow. They will now check the brachioradialis reflex, and they will strike directly 1 to 2 inches above the radial aspect of the wrist. And now checking for the patellar or quadriceps reflex, they will strike directly on the patellar tendon with the knee flexed. And lastly, they will check the Achilles or ankle reflex by striking directly on the Achilles tendon, watching for plantar flexion. One pearl is that a slowed relaxation phase of reflex can indicate hypothyroidism, and a hyperreactive reflex can also be seen with hypocalcemia. While assessing the patient's deep tendon reflexes, the provider can distract the patient by asking them to hold their hands together to prevent anticipation reflexes.
The PA will now perform a peripheral vascular exam. He will inspect for swelling, redness, color changes, temperature changes, ulcers, hair loss, skin breakdown, ischemia, and scars. Hair loss over the anterior tibia points to decreased atrial perfusion. Dry or brown-black ulcers from gangrene may also be present. The PA will now palpate the pulses for rate, regularity, and amplitude. The purpose for this exam is to see if the symptoms are due to decrease in blood flow to the extremities, such as peripheral artery disease. It's also important to remember during palpation to make sure to compare pulses bilaterally. The PA is now going to conduct a straight leg raise test. The patient is supine, and the PA will raise the patient's relaxed and straightened leg, flexing the hip joint. Pain radiating into the leg is a positive test, indicating lumbosacral radiculopathy or sciatica. Note the degree of elevation at when the pain occurs. Foot dorsiflexion can further increase leg pain in lumbar radiculopathy, sciatica, or neuropathy. Tightness or discomfort in the buttocks or hamstrings is not a positive test. The PA will now observe the patient's gait. This provides information about coordination, position sense, and muscle strength. The PA will observe posture, balance, arm swing, and leg movements.